Hello and welcome to this lecture. My name is Khushminder Chahal. I am the Chief Resident of the Psychiatry program here at Wade State University, and I'll be talking to you today about the topic of taking a sexual history. So, we'd like to begin with just asking you a few questions to get you thinking about this topic. Question number one is, how comfortable are you discussing sex with a patient? Very uncomfortable, uncomfortable, neutral, comfortable, or very comfortable? The next question I would like to ask you is, how often do you anticipate discussing sexual health with patients during your medical career? I will not discuss sexual health with any of my patients. I will discuss sexual health with a few of my patients. I will discuss sexual health with half of my patients. I will discuss sexual health with most of my patients, or I will discuss sexual health with all of my patients. So, our objectives for today are to describe what a sexual history is and provide some guidance on how to take one. And we'll organize this presentation with the what, why, who, when, where, and how of taking a sexual history. And then at the end, we will collect all that information and discuss the role that performing a sexual history plays in patient care. So what is a sexual history? Well, a sexual history is the portion of the medical evaluation that explores a patient's sexual health. Sexual health we can define, as per the World Health Organization, a state of physical, mental, and social well-being in relation to sexuality. It requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. And so when we're gathering all of this information, we're using more than just one source. And so the information that we gather could come from our clinical encounter, physical examination, laboratory testing, imaging, electronic records, or collateral sources. Why to take a sexual history is an important question that we should ask. And when formulating our answer to that, I think it's very important to understand that sex is a basic human drive and that human sexuality is universal. And therefore, it is pertinent to every medical specialty. And when we have good sexual health, we have good physical and mental health. And the other side of the coin is when we have poor sexual functioning, that can provide us insight into health problems, whether it be sexually transmitted illnesses, infections, sexual dysfunctions, or any potential psychiatric disorders. Now, who requires a sexual history? And the answer to this is everyone. Every patient requires a sexual history at some point in their care, and ideally routinely in their care. And that is not just the patients who present with sexual complaints, but even those whose chief complaint is entirely independent of a sexual history. And so therefore we have to be very proactive in our evaluation. We don't take a sexual history only if the chief complaint is sexual. Every patient should be asked about their sexual history. And patients want to talk. They want to talk about sex. A 1999 US poll of patients aged 15 and older was published in JAMA, and the results showed that 85% of respondents expressed an interest in talking to their providers about sexual concerns. When to take a sexual history. And essentially there will be two situations with which you will be confronted, and within which you will need to decide how to go about taking a sexual history. The first is if there is a sexual complaint. And in this case, the overall medical evaluation is centered around the sexual history. Usually, these patients will be referred to you, either from another medical specialty, primary care, urology, endocrine, neurology, etc., or they'll be self-referred, and their complaint could be something along the lines of erectile dysfunction. And now the other situation would be if there was no sexual complaint. And for these patients, the sexual history is a part of the overall medical evaluation, independent of the chief complaint. You'll see this more so in the routine patients. And once again, it's very important that the physician is proactive in obtaining a sexual history. Where to take a sexual history is an important question and something that we should consider. As we stated earlier, taking a sexual history is appropriate in all medical settings and all medical specialties, whether that's inpatient or outpatient, primary care, or in a specialty clinic. You want to provide a safe and private space for the clinical encounter. Ask the family and friends to step out. Only medical staff crucial to care should remain in the room. Make sure the doors are closed. We want to create a safe therapeutic space for the patient to discuss what potentially could be a very sensitive and intimate topic. And so now let's come to how to take a sexual history. First, let's discuss what you will need. You'll need a mature physician. The key to all of this is the physician, and the physician should be mature. And part of that is that the physician should be comfortable with their own sexuality and discussing issues of sexuality. A physician needs to be open-minded and respect any alternative lifestyles. And a physician needs to be non-judgmental. The patient should get the physician's full and undivided attention. You should be facing the patient, have open and welcoming body language, and be free of any distractions. That includes taking notes, working on the computer, or your phone or tablet. Once again, you want to create a therapeutic space where both you and the patient are engaged and are developing a rapport and developing trust. So, beginning the sexual history, there's no right or wrong way to go about this, but essentially there are two approaches, both with their pros and cons, and perhaps one may be more appropriate depending on the patient, the physician, the setting, and the complaint. The first of these two approaches is the subtle transition. In the subtle transition, you want a free flow of ideas which lead up to the discussion of sexual health. And so you want to start at a distance further away from the patient and from the topic of their sexual health and slowly move towards the topic of sexual health and how it relates to the patient. Some examples of this could be, quote, "Many people with diabetes notice a change in their sexual function. Have you noticed any such change?" So here we're talking about diabetes. Then we mention a potential side effect of diabetes in patients. And then we bring it closer to the patient and we ask them specifically if they have encountered any of these changes. Another example would be, quote, "What was the first date of your last menstrual period? Have you been pregnant before? Are you currently taking any contraceptives? Could you tell me a bit about your sexual health?" So once again, you see that there's a flow to the conversation. There's an understandable flow to the ideas presented and to the topics. And we're talking first about menstruation, potential pregnancy, safe sex practices, and eventually sexual practices. So that's one approach, and that's the subtle approach, the subtle transition. The other approach is announcing that you will change the topic and announcing what the topic is. And this is something that would be perhaps more fitting for a physician who is more comfortable with a structured interview, or is in a setting in which a more structured interview is demanded, perhaps due to time restraints. And so such an announcement would go something like this. Quote, I am going to ask you a few questions about your sexual history. I ask these questions to all my patients because they are very important to your overall health. Everything you tell me is confidential. Do you have any questions before we start? Now here there's less of a flow. You are announcing it. A disadvantage to that could be simply that the patient feels that the topic has come out of nowhere, and maybe they're blindsided by it a little bit, and they're less likely to open up and discuss intimate things. But on the flip side, an advantage could be that a patient appreciates the announcement and appreciates the disclaimer you're giving them beforehand. And the disclaimer you gave them here was very good in that it mentions what you're doing, why you're doing it, it normalizes it and lets them know that you ask all of the patients about this. It tells them why, because it's important for their overall health. It helps establish rapport and trust as you tell them everything is confidential. And then you open the dialogue as you ask them, do they have any questions before we begin? So two approaches on how to begin the sexual history, whether it be the subtle transition or the announcement in the change of topic. Both can be utilized by a competent physician to begin the sexual history taking process. Now, when we're conducting the interview, you want to start with open-ended questions and become more directed. And it's important to become very directed when necessary. And when I say that, what I mean is that before you move on to the next topic, you should be proactive in encouraging the patient to give forth as much information as possible before you move on to another topic. And this is very important when taking a sexual history because patients may resist, either consciously or unconsciously, as it is a sensitive subject. And as we will discuss later, even if they want to discuss it, it is hard for them to do so. So when a patient gives you an answer, make sure you fully understand before you move on to the next topic. Now, when it comes to terminology, do not assume anything. Use neutral terminology until you know otherwise. Ask if they have a partner, not a girlfriend or a boyfriend. And you may use a patient's terminology as they do begin to express themselves. You may use oral sex instead of fellatio, or climax instead of orgasm. However, it is important to maintain professionalism. As soon as their language becomes derogatory or inappropriate, it is your job to model what a mature and constructive conversation would look like, and a big part of that is determined by the language that you use. So make sure you are mindful of how you are putting this conversation into words. Repetition is a good way to elicit further information, and simply it is repeating back what the patient mentioned, and that will prompt them to explain further. So an example here would be if the patient says, quote, I guess I've been having troubles performing. And the doctor would respond, quote, troubles performing? And the patient would respond, yeah, like getting an erection. So here we can see that simply by repeating the last two words of the patient's response, we encourage them to further explain. And things like this are important when we're trying to overcome resistance. As I mentioned, patients may, either unconsciously or consciously, resist discussing their sexuality. And there are many reasons for that. Could be cultural or religious factors, could be due to guilt or shame. Such a discussion could be anxiety-provoking, could be triggering, or perhaps could even be traumatic. And what may be beneficial and may be helpful is to start further away from the topic and then slowly move towards it. So, if you are discussing sexuality or sexual difficulties in the context of a relationship, it may be useful to talk about solo acts before partnered acts, for example, masturbation. Or, what can be very helpful is to discuss fantasies before discussing reality. Asking a patient about their sexual fantasies, sex dreams, use of erotic novels or pornography preferences can elicit a lot of useful information. Patients will be more comfortable discussing their fantasies rather than their reality. Ultimately, we do respect the patient's request. If they are resisting, if they do not want to have this conversation, we do want to respect that. But we do not give up. We offer them options. If they are too anxious to discuss sex on the first attempt, you can offer another provider with whom they may feel more comfortable, a same-sex or maybe even an opposite-sex provider may make the patient feel more comfortable, and they may be more likely to discuss their sexual health. So provide them this option, and by doing so, you're also showing them that you care and that you want to have this conversation. Another thing you could do is ask them to think about it and then revisit the topic next encounter. In fact, this is such a powerful tool that a lot of times you will find that the patients will bring it up on the next encounter on their own. An example here is the patient presents the second time and says, quote, "You know, doc, last time I was surprised you brought up sex, but after thinking about it, I actually do have a couple of things I'd like to discuss." So you get the patient talking and the conversation begins. What we want to do is identify the chief complaint, identify the sexual complaint. It's important to document in the patient's own words, and this can be elicited with open-ended questions, and then, once again, narrowing in with more directed questions. And once you have the patient's chief complaint in their own words, it is important to compare that to referral sources if they are available. Whether that be a medical referral from the PCP, urologist, endocrinologist, or whomever, whether that be from some rating scales or surveys that perhaps the patient may have filled out in the waiting room, or that the triage nurse may have filled out, or from the partner or the spouse themselves. It's important to have that discussion with the patient. For example, Mr. X, I noticed you mentioned to me that you're having troubles performing, but here on the triage nurse's note, under chief complaint, she wrote erectile difficulties. Could you tell me about that? And that will elicit a conversation, as now you have two sources, and the patient is provided the opportunity to clarify what exactly they mean. When we are investigating the chief complaint, we want to ask about duration, course, and context. These are the three most important questions. Duration is when it started and how long it lasted or does last. Course is it continuous or fluctuating in its presentation? And context, does it occur in all contexts or just specific contexts? And using these three pieces of information, we can start to formulate the etiology of the complaint. And then additionally, we can ask about any past history of this complaint and how they went about managing it in the past. And it's very important, I think, to think of sexual functioning in terms of the sexual functioning or sexual response cycle. The sexual response cycle is made up of 4 phases: desire, which is your libido; arousal, which is the excitement phase; orgasm, and then resolution. And if we start to narrow down our questions with this in mind, we can start to get some very useful information that can help us formulate potentially a diagnosis. So if we were to suspect difficulties in the desire phase, ask where on the spectrum of desire they feel they are, whether that's towards the hyposexual end of the spectrum or towards the hypersexual end of the spectrum. If we're narrowing in on the arousal phase, it will be beneficial to ask about difficulties with attaining erection or difficulties attaining sufficient vaginal lubrication. Or if arousal is only attained in specific situations, in which case we may want to start considering paraphilias and further explore for specific paraphilias. When it comes to when it comes to orgasm, we can ask about an inability to orgasm, premature or delayed orgasm, pain on orgasm, or once again, if orgasm is only reached in specific situations, which would make us consider paraphilias. And if we were to diagnose a sexual dysfunction, per the psychiatric guide, the DSM-5, we do have specific disorders that we can diagnose. And should they meet criteria for any of those, arriving at such a diagnosis will be a lot easier if you have the sexual response cycle in mind and cater your questions to such a model. And you can see here on this slide how all of the sexual dysfunction diagnoses of the DSM-5 fit into particular phases of that cycle. If they have difficulties with desire or arousal, some potential diagnoses include female sexual interest/arousal disorder, male hypoactive sexual desire disorder, erectile disorder, genitopelvic pain/penetration disorder. Dysfunctions related to orgasm could include female orgasmic disorder, premature or early ejaculation, or delayed ejaculation. And then you have this category here of other, which is comprised of substance or medication-induced sexual dysfunction, any other specified sexual dysfunction, or an unspecified sexual dysfunction should you not have enough information yet to make a diagnosis. And I think one important diagnosis here to touch upon in this lecture is medication-induced sexual dysfunction, as this potentially is iatrogenic. We are potentially giving patients these sexual dysfunctions when we prescribe our medications, and that could have tremendous implications to patient care and the relationship between a physician and a patient. So when we discuss medication-induced sexual dysfunctions, we need to be aware that sexual side effects are common, particularly among psychiatric medications, but also other medications, and I'll touch upon that on the next slide. But why I mention it is because it has tremendous implications in care, implications in trust and rapport, medication compliance, or even treatment adherence. If you're giving a patient something that is going to affect them in such a personal and intimate way, they are less likely to trust you. Their relationship is more likely to be ruptured. They're definitely not going to take that medication, and they're less likely to pursue treatment and care again with you or perhaps anybody else in your specialty. And so it's very important to inquire about sexual functioning after initiating medications. For example, quote, Mr. X, last appointment we started a new medication which I told you potentially could affect your sexual functioning. Have you noticed any such changes? One question, it's a screening question, but very important to ask on follow-up after you start a new medication with your patient. Here on this slide, I've listed some medications, the more common ones, which can cause sexual dysfunctions. And once again, I've organized it using the sexual response cycle. And we have some here under desire, arousal, and orgasm. When it comes to psychiatric, the main perpetrators usually are the SSRIs, SNRIs, TCAs, lithium, and antipsychotics. Potentially some benzos can as well. But non-psychiatric medications, it's very important to remember that cardiovascular drugs can also have sexual side effects. Hydrochlorothiazide, clonidine, digoxin all can affect desire, and beta blockers can affect arousal. In addition to cardiovascular drugs, other non-psychiatric drugs to be mindful of are anti-androgens, such as spironolactone, also antihistamines and naproxen, which are considered fairly benign drugs. Antihistamines are over the counter, so it's important to ask about their medication list, not only what is prescribed, but also what they potentially could be getting over the counter. Now, if a diagnosis of a sexual dysfunction is not warranted, if criteria is not met, if it's not a disorder, but more so a difficulty or a complaint, we want to think about poor daily functioning, and we want to start considering any biopsychosocial factors. And very important to ask here is the course and the context. What changed? What's new? When does it happen? Just like with the disorders, also with the difficulties and the complaints, any sexual complaint, when we're looking for the etiology, we should approach it from a biopsychosocial perspective. Biologically, some of the potential etiologies could be endocrinopathy, neuropathy, cardiovascular disease, structural or anatomical differences, drug-induced, or as we mentioned prior, medication-induced. Psychological factors include depression, anxiety, a history of trauma or abuse, feelings of guilt or shame, and these are particularly common in patients who somatize or have somatization. We see this often in somatization that occurs in the context of infidelity. Women who cheat on their partners present commonly with pelvic pain, and men who cheat on their partners present commonly requesting repeated STI testing as they experience the symptoms of a sexually transmitted infection. Also, we need to consider issues with self-esteem and self-image. This particularly could be important in the transgender population. And also, we need to consider any homosexual conflict. Social factors include interpersonal conflict, cultural or religious restrictions, and also it's very important to think in a developmental model to consider age-specific demands and pressures. Patients in adolescence will have peer pressure and will have difficulties with their sexual identity. It's a time of separating, it's a time of becoming an individual and learning what your identity is. And those pressures should be kept in mind when trying to understand your patient's difficulties sexually. In early adulthood, there presents many pressures related to childbearing, both for women themselves to bear children, but also for men to care for them. And we see in late adulthood that these pressures to provide increase, and we also see that there is stress related to marital conflicts. And in the elderly, we see deteriorating health, and we see issues related to loss. Many of the friends and family around them are dying. It's making the patients think about their own loss. They're reflecting on their life, and perhaps are not as capable to perform sexually due to their deteriorating health. And so this is also something to keep in mind. So that was all if we had a sexual complaint, the patient was able to identify a sexual complaint. But the other situation is if there is no sexual complaint. As we stated earlier, it is important to take a sexual history on all of our patients, regardless of whether the chief complaint is sexual or not. So if the chief complaint is not sexual, and we are still going to conduct a sexual history, what exactly does that look like? Well, what we want to do is gather basic elements. This includes sexual identity. Are they male or female? But also, you need to follow that question up with what is their view on their birth versus their experienced gender? They may say that I'm clearly a man, I was born a man, I have male genitalia, but it's important to ask how they feel about being a male, or if they've ever felt as a stranger inside that body. And if there is a discrepancy between birth and experienced gender, it may give rise to the consideration of any transgender related issues. But also, it's very important to consider the patients who do not view gender as binary, who view gender more so on a spectrum and therefore identify themselves as non-binary. When it comes to sexual orientation, it is important to ask about hetero versus homosexual orientation, but once again, you will have patients who view things as a spectrum rather than in a binary manner, and they would consider their orientation to be pansexual. When it comes to relationship status, this is something that is commonly asked and not missed by physicians, and that's great, but I think they forget the follow-up question. The first question is, are you single or in a relationship? And it's clear why we ask this. Those who are single are more likely to have multiple partners and therefore are at higher risk as they expose themselves potentially to more illnesses or infections or the risk of pregnancy. But if the patient says they are in a relationship, it's not enough to stop there. Then you should ask about the nature of that relationship. Is it an exclusive relationship or is it an open relationship? If it's an open relationship, the risk still applies as it would if the patient were single. You can then ask if they are sexually active or inactive and any potential sexual behaviors which they do engage in. And the reason we do all of this is for a risk assessment. What we are trying to do is gather information to help us formulate management for risk reduction. And this would allow for interventions which promote preventative medicine. And when we think of risk, we're thinking of pregnancy, infection, and any potential disease. And a very useful screening tool is the 5 Ps. The 5 Ps are partners, practices, protection from STDs, past history of STDs, and prevention of pregnancy. And you can see here on this slide, taken from PriorityHealth.com, which was adapted from the CDC's guide, released in 2006, you have a screening tool here which outlines the 5 Ps and any questions that go along with it. And you can take a minute here to pause this slide and read over how specifically you would ask about those 5 Ps. And when it comes to tools such as these, screening tools, we should also consider what the role of psychometric assessments would be in taking a sexual history. Psychometric assessments include scales or surveys. We have to keep in mind that very few are validated and none are diagnostic. However, they may play a role in quantifying the patient's report. For example, Mr. X, you told me you were having some difficulties, and after we completed this scale, I can see you scored a 28 out of 30, and that tells me that you have a quite severe a degree of distress or dysfunction. You can use this to monitor progress. If you do implement an intervention, then at follow-up, let's say at 6 months, you can repeat the same assessment and see if there's a difference from baseline or from the first encounter. For example, Mr. X, when we took this assessment 6 months ago, before our intervention, you scored a 28 out of 30. Now, after 6 months of care, I see the score has decreased to 28 out of 30. And this can all be very useful for providing feedback to the patient, as not only are we keeping them up to date on our progress, but it can stimulate a dialogue between you and the patient of how the journey has been thus far and where the patient would like to go next. For example, Mr. X, now that we're at a 23 out of 30 versus the 28 out of 30 we were at 6 months ago, how have you felt about the progress thus far, and what would you like to see happen next? I've included here 2 common psychometric assessments, but they are quite different in the fact that the Arizona Sexual Experience Scale is self-rated and is only 5 items and takes less than 5 minutes to complete, whereas the Changes in Sexual Functioning Questionnaire is both clinician and self-rated, is 35 or 36 items depending on gender, and can take up to 20 minutes to complete. So you can see here, there is quite a range in the psychometric assessments available. On this slide here, I've listed some others, which fall somewhere in between, and which may be for a specific indication, but you have plenty of options should you want to implement that into your patient's care. And so now what? We've conducted our sexual history, we've gathered all this information. Why did we do it? Why was it important? How can it help us? And the importance in patient care can be described in 2 parts. The first is that it is diagnostic, and we've outlined some of the ways that the patient's subjective endorsement can guide our diagnosis, but also that information can set up some further diagnostic workup, whether that be blood work. Commonly, we could ask for testosterone, estradiol, TSH, prolactin, or sex hormone binding globulin. whether that means imaging, like a Doppler sonography, a falloarteriography, or a falloplasmography, or any other specific indicated tests, such as evaluation of nocturnal penile tumescence, or a more thorough physical examination. And then ultimately, this helps us with our management. We want to refer to the specialist that's appropriate and get them involved in our care, whether that's endocrine or neurology or psychiatry or whomever. And then it provides us, as the provider who conducted the sexual history, it provides us the opportunity for, number one, education, and number two, intervention. The opportunity for education, I think, is something that we should really stress. As providers, as physicians, we are the patient's source of knowledge, of information. They come to us for advice, they come to us for information on various topics. And for this topic in particular, which is their sexual health, it's a topic which there is a scarcity of reliable information. Sex is taught early in life in schools, but depending on where you went to school, depending on how you went about school, you could have learned it a lot differently than somebody else learned it. And there's a great deal of variation of what is taught regarding sexuality and sexual health. It's also something that we don't discuss often in society, in a lot of places as well, depending on where you come from and your background. It may be discouraged to talk about or pursue or express anything related to sexuality. And so even if a patient wants to discuss their sexual health, they might not know how to go about doing it. They might not have the mental framework of what a mature and efficient conversation about sex looks like. They might not know how to put their distress into words. And this provides us as physicians the opportunity to step in as competent medical providers and provide them with the information that they need, whether that be gender and identity issues. For example, providing resources for a transgender patient, letting them know that there are transgender communities and support groups there and resources. Whether it's age-specific sexual changes, for example, discussing with your adolescent patient what puberty looks like, what's normal, what's not normal. Whether it's discussing sexually transmitted infections and safe sex practices, or pregnancy prevention strategies, providing information on barrier protection, oral contraceptives, intrauterine devices, and implantable devices. Or, depending on where you practice, the ability to provide education on abortive resources. And then we also have the opportunity for intervention. Medication commonly is a part of that, whether it be estrogen gels or phosphodiesterase inhibitors, that paired with also the opportunity to intervene with therapy, referral to different types of therapies depending on the patient's complaint, whether counseling is an option, support groups, relaxation techniques, coping skills, but most importantly, the sexual history taking itself is an intervention, and it acts as an intervention as it models a mature and responsible discussion about sex, which is something that very few people have had, and by giving them that, you are providing them with the framework of how to go about having a mature and efficient conversation about a topic as personal as sensitive and as intimate as sexuality. So in conclusion, it's important to remember sexual histories are relevant to every aspect of human health. Sexual histories are therefore appropriate in all medical settings. Sex is a sensitive topic, but an important topic. Physicians must be comfortable exploring this topic with patients. Doing so allows for a risk assessment and promotion of preventative measures, diagnostic workup of any symptoms, and the identification and treatment of any complaints. Because ultimately, treatment of sexual health equates to treatment of overall health. So I'd like to end here by asking those questions again that I did before the presentation. Question number 1, how comfortable are you discussing sex with a patient? Very uncomfortable, uncomfortable, neutral, comfortable, or very comfortable? How often do you anticipate discussing sexual health with patients during your medical career? I will not discuss sexual health with any of my patients. I will discuss sexual health with a few of my patients. I will discuss sexual health with half of my patients. I will discuss sexual health with most of my patients. I will discuss sexual health with all of my patients. Thank you very much for your attention during this lecture. Here are my references. Thank you.